Assalamu alaikum. We are going to talk today about an important topic, namely the aortic arch, what's being done, where we're going, and what are the advances in the near future. It's an important topic. As you know, thoracic stents have revolutionized the treatment for thoracic aorta or for many pathologies that were very difficult to treat in the old time. Since the past 20 plus years or more, actually, since the past probably 25 years or so, thoracic stents have added a significant advances and improvement in the treatment of thoracic aorta. If we are going to talk about when you look at the arch now, what is the gold standard for treatment of an arch pathology? There's no question that the gold standard is the replacement of the arch, and this meta-analysis was done with basically 64 studies, almost 8,000 patients. 30-day mortality was 8.9%, stroke rate was 7.1%, paraplegia 3.4%, and renal failure was 14.9%. And if you look at the ages, the male comorbidities is the usual player. Smokers, the usual players in vascular disease. These are the cohorts of these. And these findings in the previous meta-analysis were confirmed by the study that looked into STS database, the STS arch strategies. So they looked into 12,521 aortic arch repairs from 2011 to 2014. They had basically only 7.5% of these cases were total arch replacement. Overall mortality was 12%. Stroke rate was 8%. So it's comparable to the previous study, although the mortality here is higher. And here they looked at the redo versus non-redo, again for the arch and for proximal redo. So obviously they found that there's more mortality or less survival with redo in the proximal, and possibly comparable studies with the comparable results in terms of the arch redo in experienced hands. So what are the tape blight? I mean, this is a great repair, everything is good, but what can happen with these repairs? You can have additional aneurysm in the residual aorta. A lot of times people would put a graft and then they will patch. They do like Corel type of patch for the head vessels or the arch vessels, and these can become aneurysmal. These can dissect. Pseudoaneurysms from anastomosis can happen. Infection of prior stent graft. And you see, this is this is somebody who had, it's an illustration of somebody who had a patch repair, and the patch got major aneurysm right now. So frozen elephant trunk results, again, this is single study for 100 patients in Germany. Mortality is 7%, stroke 9%, paraplegia 7%, and dialysis. So the numbers varies between studies, but they're pretty close. So this is not a walk in the park procedure. This is a very difficult procedure that has basically bears mortality results. When you look at the newer, and this is the frozen elephant trunk, so what it is, you replace the arch and you put a stent, and I don't really want to go in details, but there's a device called Thoraflex that's been used. There are multiple devices are used now. There are devices or grafts with bare stents are being used right now for that. But I wanted to discuss a modified frozen elephant trunk, which basically you have a patient with type A dissection. They treat the type A dissection at the same time in the OR. They would place a descending stent, and the survival rate with this technique, if you have time and you know how to do it, has been they showed improved survival with these patients. In our institution, they do this quite frequently. Almost every patient who can tolerate the 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 modified frozen elephant trunk basically can they'll get it. There's a lot of patients in our institution that they come with this now. This is a case where you had a patient, again, Jehovah's Witnesses with pseudoaneurysms in the arch, and as you see, there's clear hematoma. He had a previous TVAR. We did for him 2-branch Terumo, as you see here. The device deployed, and then the post-op CT showed endoleak initially, and repeat CT scan a month, endoleak was basically gone. And the endoleak, as you saw earlier, was at the left carotid area. The current trends now with these procedures is 3 branches and now even percutaneous. So it used to be you do 2 cut downs on the carotid, and you do 3 branches, and you do branch device like you would do with gore. You snare the wire, etc. But even more research now and more procedures are being done with these percutaneous through a steerable sheath and through the groin. And there are multiple reports about these super complicated procedures being done that way. And the reason is, if you look at the multi-center global early feasibility study for 3-branched devices, they had 5-axis complication, and they have basically one kink, and the stroke rate was 5%, but they had a lot of axis complication, and therefore this group of physicians, Holland, Aldrich, and Terrell in England, they went in and they did a percutaneous procedure. Obviously, it has to be reproducible. It has to be technically feasible. It is, in the people, in the operator who do a lot of these are doing these now, and where they access from the groin with a steerable wire or steerable sheath, they act it acts as a stabilizer, and then they cannulate all these vessels, and then they access the innominate from the axillary, from the subclavian, and the axillary sheath here is the safety net, just in case if they need to stent the axillary artery or the subclavian artery after they've accessed it, because sometimes it's hard to close. But in this report, they stented it after they deployed the device. And this is the device. If you look at these studies, they have variable results but comparable, except for in some studies where it's 18% stroke rate, but then the volume is about 11 patients. And again, Terumo graft was 8.4%. But you look at the major operators that they operate, they have lower stroke rate in general. It ranges between 2.6 to 7.4%, depends where you go. That's the average stroke rate. In terms of paraplegia, it's not common with the arch repair, but it can happen. We've had one that developed paraplegia 24 hours on the second day of surgery, but we were able to rescue the patient, rescue him with lumbar drain, increased blood pressure, and he was anemic at the time. His hemoglobin was 8, so we increased it to 10, and this was enough to get the patient spinal cord function back. If you look at the SVS database, and again, SVS database is very heterogeneous because there are multiple operators, different skill levels, different institutions, different capabilities, and the amount of TVARs were done in zone 0, you see stroke rate is 11%, whereas mortality is 6.9%. And when you look at and it's 350 patients, when you look at the zone 1 and zone 2, stroke rates dramatically less, and that's statistically significant studies. But again, when you look at the VQI, the operators are heterogeneous again, with different capabilities. But again, 11% is a little bit high, than most serious operators outcome, but it's still within probably just slightly higher than the. As you see in this chart, the stroke rates has dramatically decreased over the years as people gained more experience, more careful. CO2 flushing. There's not enough time in this presentation to talk about how do we prevent stroke or minimize stroke risks from during TVAR. But one of the things that we do and it helps is CO2 flushing. And in vitro or in the lab was proven in multiple studies that air embolism can actually happen and can cause problems. The feasibility study for total arch endovascular repair using 3-vessel company manufactured device, which is Cook, in this area, they found basically single center experience with 5 Cook devices, 100% technical success, 0 stroke, 2 axis complications. Again, axis complication in these cases are because they have large sheath, usually 22, 24. 1 PMAG developed graft infection 1 year later, and 6 endoleaks first month, but resolved. Sometimes most of them resolved. Like I showed you before, we had that endoleak in this patient, but within a month the endoleak has gone away. And this is the custom made devices, basically fenestrated. As you put a goose snare, you make the hole and you put a goose snare and you saw the graft like you see in this picture, and when you do a custom arch repair, you have to be essentially very methodical. You have to go back to your drawing board. You have to draw and measure and meticulously design and put everything in perspective. And as you see, you can make an opening, you can sew it, and you can basically sew the stents as seen in the third picture. Just central line measurement, you measure the distance. You have to be very, very, very meticulous. I put this picture because I think in the next maybe 10 years or maybe less even, maybe the next 7-8 years, you will see this picture on the right hand side where you have a coronary stents, aortic valve, ascending graft, arch graft. Here's this cardiac subclavian bypass, but probably we're going to see more of a 3-branch device than that. This would be a common thing that you could see in patients, and actually you see it now. You see, as you see in this case here, is a 2-branch device with cardiac subclavian bypass, TVAR. This patient had a candy plug for the false lumen. And final thoughts, these procedures are safe in the right hands, right institutions. They can be safe and alternative to open conventional therapy in patients who, especially in redo patients or patients who can who's in the right place and have the right anatomy. No randomized trials was actually done. It's all based on expert opinion studies, retrospective or prospective studies. You have to have a team with high volume that's capable of doing open and endovascular treatment to be able to do these cases. And I encourage everybody from the audience, if you tackling these issues, you have to have a team. You have to have a conference basically, and you present the patient on these conferences, and you see what best for the patients, open, endo, or sometimes do nothing. 2-branch devices are no longer experimental. 3-branch devices are underway. Percutaneous is coming. And in summary, patients should be referred to high volume institution with advanced open and endovascular capabilities. Like we said, you have to have a multidisciplinary approach, preferably a conference. The root and the ascending aorta must be healthy and not dilated for successful endovascular arch repair. Endovascular arch technology is still evolving. Physician modified graft, PMAG, provide custom branch fenestrated TVAR solutions in certain cases, emergencies, but there's outcome with them maybe a little bit not as good as, and depends on the experience. But one has to really follow these patients closely. Trends toward inner branches, the transfemoral implantation without cervical deep branches access. Again, this requires a lot of skill, so it should be done by people who have high volume. And endovascular treatment of arch pathology is suitable for redo arches or poor surgical candidates. This will save their lives, or emergencies. And I'm sorry I took a little bit of time to go through this, but I think pretty much I had a general overview about these conditions and what's out there nowadays and what we are going to see in the near future. And if you have any questions, please feel free to contact me, and thank you very much.